Hello, I'm Janice Karen, Director of Policy, Technology, and Innovation at the Massachusetts Health Data Consortium, or MHDC. I run our Data Governance Collaborative, also known as the DGC. We start each of our weekly meetings with a series of industry quick updates to learn about new and proposed regulations, laws, standards, industry initiatives, and other activity. Join us for this week's updates. And if you'll go to the first update, ASCP has put out another one of their really interesting data briefs. This one is on standards adoption by HIE organizations. I don't know why, but they're instead of calling them HIEs, they're calling them HIOs. They've added organizations to the end, and then they're abbreviating it as HIOs. So what they've determined is that most HIOs support HL7 version 3 CDA documents and HL7 version 2 messages within the context of their full range of support. About 2/3 of them, most of them support about 2/3 of the data elements in USCDI in total. It's up to almost 3/4 if you look at USCDI version 1 and version 2, and it drops down to 2/3 when you hit version 3 and version 4. So with the stuff that's currently mandated for support in regulations as of today, they're closer to 3/4. Areas where there's pretty good conformance include immunizations, problems, vital signs, and encounters. The single worst, interestingly, by far the single least supported data element is sexual orientation, which is almost down to 1/3. But interestingly, there's only these 4 that are at 51% or less. So considering the overall support, there's a lot of mix of what isn't supported in different places. Because if other than sexual orientation, the worst cases are at about 50%, and the total support is 73%, it's not super consistent about which portion, which 50% different, which 73% different HIOs are supporting. So I thought that was interesting. They also said that organizations were more likely to send than receive data. However, there was a large percentage of organizations that just weren't sure. Not clear if that's a lack of understanding of what USCDI is, or if they're not entirely sure what they're getting sent. Like, if it's not clear why, they don't know, but about 30% don't know. But even with the nevers are down to are at 8 and 13%. But if you combine those with the don't knows, it's still about a third to close to half. So still not
But
terrible.
I'm assuming
And
this
go
is
ahead.
national numbers, right?
This is national, yes.
And so, I mean, pure the pure nature of HIEs and USCDI don't necessarily go hand in hand. I mean, USCDI is a relatively, new data qualification, whereas the HIEs and the CCDAs, I mean, I can understand why you wouldn't see some of this data in there because it's just not something that would ever be part
Well,
of a CDA
well,
document.
actually, it is supposed to be part of CDAs. USCDI is format agnostic, and there's lots of USCDI data inside CDAs.
Yes,
So
but like sexual orientation and things like of that nature, right? That wouldn't be something that HIEs would have been collecting past.
right. But they have gender identity. Gender identity is not on that list.
Yeah,
To me, it's weird that they would have gender identity and not sexual orientation. But um, but be that as it may, yes, I mean that's certainly part of it. And when we go on to the next page, what you'll see is that about 20% of them are supporting FHIR in some fashion. So there is some level of mixed support of how the data is getting exchanged across the HIOs. And Ashley, why don't we go ahead and go to the next page? So you'll see that last bullet point, which was interesting. So that's routinely or sometimes send or receive data via FHIR. They didn't break it out further than that. but that actually was a higher number than I was expecting. So I thought that was interesting.
No
But
motivation for them to do that.
what's that?
There's no real motivation for an HIE to accepting FHIR transactions.
Yeah, there's starting to be a few places where it's going to be required, but they're not there yet. Like some of the public health stuff, which is often done through HIEs, some of the new requirements for public health are going to require using FHIR, assuming that HTI2 gets passed the way it was written. But that's still a couple of years. So anyway, as you can see from the slide, one of the big areas they focused on was laboratory data. And a lot of the data was coming in non-standard formats. So there's a lot of HIOs that are mapping from non-standard formats to LOINC codes. And you can see it's only 3% that don't map codes at all. And 20% that only do a little bit of mapping. So 80% are doing, I'm sorry, 80% of the folks that are doing mapping, so 46% are doing mapping. 50% say it's pretty easy for them. Of the ones that are doing mapping, about 75% map at least some, what they would consider some, versus a 20% few or not. So there's a fair bit of mapping happening. I actually think that the 50% having no issues is high. I'm sorry, go ahead.
This number seems really high, right? I mean,
Yeah.
LOINC, this seems really high to me. I mean, the HIOs should be getting this data in ORU format, and that should all have LOINC codes in it. I'm surprised that there's
Well, it depends on where it
this much
comes
mapping.
from, right? Because one of the issues that I've run into, I know I've gone to some discussions about laboratory-based projects where they were trying to move to FHIR, and one of the issues they ran into was that the providers in general wanted LOINC, but the laboratories themselves were using other code sets. And so if the data is coming from the providers, presumably a fair bit of it would be in LOINC. But if they're also getting data from laboratories directly, at least this was a couple of years ago already, but at that point in time, there were a lot of laboratories that were not using LOINC. They were using other code sets. And in fact, I know of at least 2 projects that were halted by the idea, but basically folks said, well, we're using different code sets. We can't talk to each other. We can't do anything.
So this is okay. I think I'm reading this wrong. So this is saying that half of the HIEs are doing some kind of mapping. It's not saying that half of the lab data that's coming in is non-LOINC compliant.
That's right.
Okay, that I could potentially see that.
My guess is that all of them have some data coming in that's not in LOINC, but
Right.
some of them are not
Some right. Some bad interface stuff that's coming from, some lab that is not really on top of the LOINC HL7.
Yeah. So anyway, these are always interesting. You can follow the link if you'd like. As usual, they do have nice graphics. They do go into a little bit more detail on some of these items if you're interested. And I think that they've done most of, if you go back and look at the data briefs that are available, they've done a fair bit of types of organizations at this point, either FHIR adoption or standards adoption or both. So if this is an area that you're interested in, if you go to the data brief section entirely, you should be able to find other reports as well. Anyone have any other comments or thoughts or questions here? All right, let's keep going then. So as part of Cybersecurity Awareness Month, HHS OCR has put out a new video on ransomware trends. In addition to trends, it provides some guidance. It talks about some best practices, and it has some analysis of the ransomware attack chain. That's the typical stages of an attack. So I have not watched the whole video yet, but it came recommended, and I wanted to pass it along to folks if you're interested in that. So any thoughts or comments? Again, I haven't watched the whole thing, I've watched part of it, but I can try to answer any questions people have. All right, let's keep going then. In a similar vein, for HHS's 405D, which is one of their cybersecurity organizations, has put out a poster on how to protect your devices that connect to the internet. It's pretty basic stuff, but if you're in a place where people have a lot of devices, whether that's tablets and phones or medical devices, and you want to have a wall poster that just to remind people of good practices, this is available to be printed out. Anyone have any questions or thoughts about that? All right, let's keep going. So the 2024 LEAP Award, which is every year ASTP puts out 2 awards. Basically, it's a grant to work on a health IT project, and they pick a different specific topic, 2 specific topics each year, and you pick which one you apply for. So the 2 topics this year are the hyphen bullets: innovative ways to improve healthcare data quality and support responsible AI development. And that was awarded to Columbia University with the project listed. And then the other topic, the other award area was accelerating the adoption of health IT and behavioral health settings. And that was awarded to Oregon Health and Science University. You can find more generally about the award on the first link. And then the second link goes into more detail about the projects that each of these 2 award winners are doing. Anyone have any thoughts or comments or questions there? All right, let's keep going then. So the Senate has put out a rather scathing report on mostly post-acute care, prior authorization denials, and Medicare Advantage. And they focus on United Healthcare, Humana, and CVS. And it mostly looks at the years between 2019 and 2022, although there are some areas where they have a little bit of 2023 data, I believe. So basically, I'm not going to read all of these word for word, but you can see from the slides that the denials of prior authorization for post-acute care were far higher than in other areas, as much as 16% higher, and that they increased over time as well. You can see the example just from 2020 to 2022. United Healthcare went up from just under 11% of denials, which still seems kind of high to me, to almost 23% in 2022. And they said it specifically coincided with the increased use of AI in the decision making. For CVS, the denial rates remained steady, but many more services were subject to PA, so they ended up with a much higher number of denials. And CVS specifically reported in May of 2019 that they saved $660 million in 2018 from these denied admissions. So it was something that they were specifically looking at in their financial reporting. They also there's also evidence that they rejected a predictive model that they felt approved too many cases they thought should be denied. And when they compared the approval rates in the testing bed versus the actual acute hospital admissions in the same time, there was an order of magnitude difference. It was 10% higher. And they now, no one's saying that maybe there were some issues with that algorithm and maybe it was too generous, but that's a pretty large difference when they were specifically looking at that. Any questions or comments so far? All right, let's go to the next page. So again, Humana's rate, they looked separately at each of the 3 companies they focused on. Humana made specific changes to the templates that they use for medical review to specifically to enhance the ability of the company to uphold their denials on appeal. And then when they started rolling back their relaxed COVID prior auth requirements, they stressed pretty strongly that post-acute admissions were high-cost interventions, and they encouraged other options pretty strongly. So 3 recommendations came out of this report, and these are ones that would, in theory, affect anyone doing Medicare Advantage. So people on this call, most likely, that the way that prior authorization information is collected should be based on service categories, so it's easier to do more analysis of the prior authorization rates. That there should be targeted audits of payers that show they've increased denial rates, and there should be some regulation around the use of predictive analytics in prior authorization processing. So you can find the full report. I think it's about 50 pages at the link. And like I said, they focused on those 3 companies. I'm not trying to pick on them, but I think the upshot is that it's likely that there will be a change, some additional regulation around prior auth, particularly for Medicare Advantage, and possibly around the use of AI, but definitely in the reporting requirements, I would think. Anyone have any comments or questions? Dave, any thoughts, anything you'd like to comment on there as our resident prior auth expert?
Yeah, well, these are all MA plans, Medicare Advantage plans. It seems that this study was focused on that. So they are subject to the prior auth rulemaking under the new CMS rules. So that's good in that, they're going to be required to, adhere to the API-based prior auth mechanisms, which at least will make it so that there's more visibility, transparency, and reporting. There is a pretty significant reporting requirement built into that regulation. So whether it comes down this way through directly from HHS to the MA plans, or it comes via the new proposed rule that will be implemented by January 1, 2027, then either way there's going to be a lot more, I guess what I would say, control points on these activities over the upcoming years. So that's good news. Yeah.
I don't remember. I don't remember the reporting rules for the CMS API rule. Does that include, like, do you have to categorize that by the type of admission that's denied? Like, if you were doing admissions, do you have to specify it's like post-acute care?
Yeah, it's a type, it's a complete reporting of the total, like numerator denominator, just like quality measure reporting. So it's the total PAs, the number that were done electronically, the number of denials, the number of approvals.
Right. I remember it being like overall, but I didn't remember I didn't remember off the top of my head there being category requirements.
There aren't in the CMS rule, but people are contemplating it. And certainly health plans are going to want to do it for their own reporting.
Right.
I think one of the things that strikes me about this is that this has been shifted from the physician, who was, the one most burdened by prior auth under the prior, sort of argument. And now it's kind of shifted to hospitals and to their post-acute partners, because this is like an institutional shift, These are not requests for prior authorization that are coming from the doctors. They're coming from hospitals who want to discharge patients through discharge planning to the next appropriate level of care. And it's interesting. It would be interesting to learn more about what the denial, if any information is available. I doubt it is, but what the denial reasons were and what were the most commonly cited reasons for delay or for denial. But this is kind of a shift. This looks like almost a strategic shift on the part of some of the national plans to take the prior authorization focus from the acute care encounter with a doctor and a patient where there was the most friction to now the hospital setting, the facility setting, and their attempts to get prior auth for their patients who need to go to some post-acute care.
Yeah, we can take a look and see if there's any additional data on that available.
Yeah, and what's also a little interesting on this, Janice, too, is the post-acute care is typically after an acute care incident, so
Right.
post-acute, obviously, which isn't necessarily focusing on the admission itself. So it's after that usually is
Yeah.
what
Well,
would be classified here. So that, to me, that's a different, view. It's kind of a pretty narrow view of the whole PA processes. And post-acute
if
care has always been difficult. Yeah, go ahead.
yeah, if you go back to the previous slide, this is not.
Yep. Mhm.
I categorized it as post-acute care in the heading because a lot of the stuff they talk about was, but it
Mhm.
wasn't entirely post-acute care in the report. Like, if, for instance, if you
Oh.
look at the last CVS comment, that was acute hospital admissions.
I saw that in the way it was worded here, and I thought that
Yeah.
maybe they were kind of mixed together. So, but maybe that term post-acute care should just be
Yeah,
more
maybe I
general.
shouldn't put it there, but most
Yeah.
of the stuff that they commented on was specific to post-acute care, but they clearly looked at other areas too.
Right.
And I didn't, there's probably stuff buried in there where they're more general as well. But in
Yeah, it
terms of the
didn't.
things that they saw as notable in what they looked at, these were the things that they pointed out in particular.
Gotcha.
So,
All right.
And there are
Great.
Alright.
post-acute models like inpatient rehab, which may be according to some of these health plans policies is better done as outpatient or home-based rehab. These are complicated because there's a lot of different post-acute settings, as Dave pointed out.
Right.
Yeah.
Yeah, right.
All right. Well, let's keep
Okay.
going unless someone else wants to chime in. Let's go ahead and go two slides up since we went back one. So I believe this is the last one. Peterson Health Technology Institute did a survey of digital health purchasing this summer, and they talked to 332 folks from a mix of payers, providers, and employers that supplied tools for their employees. And it asked them about their current approach, their contracting process, and their future plans. And some of the takeaways were not very surprising. Some of them were maybe a little bit more surprising. Spending has increased. It's expected to increase more. The one thing that was interesting, one of the things that was very interesting was that each of in general, the purchasers developed their own evaluation criteria, so they weren't relying on any type of standardized review setup or standardized mechanism or recommendation system. They were evaluating things themselves, and they did usually include some type of performance metrics in their contracts, which were short contracts. And then the other thing was that they don't see the clinical priorities for digital health changing much, but they do want to use it to support risk-based contracts more heavily. So I thought that was kind of interesting. The three biggest focus areas right now, I know I'm skipping around a little bit on the slide, were diabetes, primary care, and mental health. Primary care is a very nebulous category, so it's not entirely clear to me what is being bundled in under the rubric of primary care. But that could be all kinds of different things. But in general, those were the three biggest focus areas. So any comments or thoughts or questions there? All right, well, there's a link to the full report if anyone is interested in more. All right, and if you'll pause there for a second, I hope you learned a lot from our quick updates. If you're interested in finding out more about the DGC and its other activities, email me at dgc@monthealthdata.org. That email address is also on your screen.